Hello. This slide presentation will talk about alterations in respiratory, ears, eyes, nose, and throat functioning. These first three slides show you in words the parts of the respiratory tract, both the upper respiratory tract and the lower respiratory tract, a picture diagram of where those structures are located, and then the third slide is a link to Khan Academy, where I recommend that you review respiratory physiology if you need a refresher on these concepts. General assessment of all of these alterations includes assessment of respiratory rate, the depth of respirations and the rhythm, breath sounds, whether they're normal or if there's some abnormality, the child's respiratory effort, or do they look comfortable breathing, or do they look like it's really taking them a lot of effort to do so, their heart rate, their oxygenation status, their hydration status, their body temperature, their activity level. Are they engaged in activity or are they too tired to engage in it? And their level of activity or their level of comfort. So the care that we provide for our children will include easing their respiratory effort, promoting rest, promoting comfort, preventing the spread of infection, reducing body temperature, providing good nutrition, family support, and education. So a child is in respiratory distress when the child shows that he or she is working hard to breathe and is not getting enough oxygen. Some of the signs and symptoms that we see in our children is tachypnea, so elevated respiratory rate, nasal flaring because they're trying to increase the size of their airways, retractions because they're really working to breathe, grunting, that's the attempt to keep the alveoli open, stridor or wheezing because there may be some sort of resistance in the airway, tachycardia, cyanosis because there is not enough oxygen getting around their body, seesaw breathing, so what you will see is when you look at their chest and their abdomen, it will be going up and down opposite each other like a seesaw would. They may be sweating because of the work of breathing. You may see them head bobbing so that when they go to take a deep breath in, their head will go up and then go down with expirations. And also changes in alertness. As the child is breathing and working hard to breathe, they become less and less alert because they're also unable to get rid of the CO2, and that will change the alertness. So management of respiratory distress does include about 4 prominent factors. First, we're going to promote oxygenation. And in doing this, what we're going to do is we're going to try and increase the amount of oxygen going around their body. The easiest way to do this is to administer oxygen. We do this via nasal cannula, or sometimes we need respiratory support such as CPAP or BiPAP that will give them a little bit of pressure also. But the easiest way to increase oxygenation is to provide oxygen to your patient. Ease the work of breathing. This could be done in many ways. Generally, if we put children or any patient with their head up, that will make it easier for them to be able to breathe. We can also use different, we could also open up their airway a little bit better by suctioning, making sure that they have a clear airway. We can also increase their work of breathing and make it easier by providing chest PT. That chest physiotherapy will help open up their lung field. So there's different ways in which we can ease the work of breathing. We're going to promote rest. We're going to insist upon rest periods. The rest periods have to happen in a room that is quiet and comfortable so that they can rest and take a nap. And we're also going to promote comfort. Comfort usually comes easier when they have a easier work of breathing and they are well oxygenated. So usually fixing those two problems will make it more comfortable, but whatever they need, making sure that there's pillows supporting them when we have them in a position with their head up, anything that we need to do to promote comfort. So in the hospital, we use pulse oximetry to determine how well a child is oxygenated. And this is a picture of the pulse oximetry probes. As we talked about, or you should have talked about with your clinical instructor in the on-campus day, there's a specific way in which you need to place the pulse oximeter. So the pulse oximeter has little lights on it, and the red light should be on top of the nail bed, and then the other side that's silver should be on the opposite side of the nail bed. So depending upon the size of the child, you would use a different size pulse oximetry probe. So sometimes it's hard to use a finger or a toe, so that for a neonate or infant especially, we may wrap it around the hands, we may wrap it around the wrist, we may wrap it around the foot. So at that point in time, it's important to have a pulse oximeter probe that is big enough that the two dots will oppose or be opposite each other. This video shows you what respiratory distress looks like, and it also shows you the difference between mild, moderate, and severe respiratory distress. It is important for you to watch this video and learn from it. I had a hard time getting this to post in the video, so please copy the address and watch it on YouTube. When a child has respiratory failure, there is an inability of the respiratory system to maintain adequate oxygenation of the blood with or without carbon dioxide retention. This can happen over time. It can be gradual and progressive deterioration, or it can happen as an emergency situation. The most common cause of cardiopulmonary arrest in children is due to respiratory failure. But respiratory arrest is something different. Respiratory arrest is when there is a complete stoppage of all respiratory effort. So there is some respiratory effort with respiratory failure. And then a different term is apnea. Apnea is the cessation of breathing for more than 20 seconds. So there's a longer pause in between the breaths that the child takes. But respiratory failure is something that we have to worry about on children because we want to recognize the respiratory distress first so that it doesn't become respiratory failure and then ultimately respiratory arrest. So these are the list of the clinical manifestations of respiratory failure, and there are some cardinal signs. So if a child is restless, if they're tachypnic, if they're tachycardic, and they're diaphoretic, then this is an indication that they might be in respiratory failure. There's also more severe signs, and these severe signs occur as the respiratory failure continues over time, and so that the child may also develop hypotension or hypertension. They might have vision problems. They will probably be very silent, very quiet, and ultimately they can go into a stupor, a coma, have depressed respirations, and then it will lead to arrest. So next we're going to talk about upper respiratory infections, or URIs. So there are many different types of URIs, and we are going to talk about each one of these listed here separately as we proceed on in this lecture. So acute viral nasopharyngitis is the healthcare term for the common cold. This can be caused by different viruses such as rhinovirus, respiratory syncytial virus or RSV, adenovirus, enterovirus, influenza virus or the flu, and parainfluenza virus. The symptoms that we see are more severe in infants and in children than they are in adults, and the symptoms may last up to 10 days. So the clinical manifestations that we see are fever, irritability, poor feeding, anorexia, sneezing, abundant amount of nasal mucus, and it's at this point if the children, especially younger children, infants, and neonates aren't able to handle the secretions, then they may need to be hospitalized. Muscle aches, headaches, vomiting, general tiredness, sore throats, and sometimes a cough. So the therapeutic management for this is rest, antipyretics for fever, a humidified environment, oral hydration, And then decongestants if the child is greater than 12 months. However, the AAP does not recommend over-the-counter cough and cold medicines for children who are less than 4 years old because they feel as though that they don't work, so the benefit of using them does not outweigh the risk because there are potential health risks for giving that to younger children. So some of the nursing care we will provide is education, educating the parents and the children to keep the head of the bed up. That will make it easier for them to breathe. Suctioning, teaching them how to keep the nose and airways clear. We may teach parents how to use nasal saline drops and how to get them out with a bulb syringe. Maintaining fluid intake, that's really important, especially when our children aren't feeling well, they will not drink. Disposal of tissues, so the virus is going to be living on the tissue, so we need to make sure that the families and children know that they need to dispose of them in a trash can. They shouldn't leave them on counters or all around. That it's important not to share towels, glasses, or utensils because this is a way in which the viruses can be transmitted from one person to the next. We want to make sure that they cover their mouth when they're coughing and sneezing, and we're going to talk to them about doing so into their antecubital area so that if they were to cough on their hands and touch something, they could spread it. Washing hands is real important. That's one of the best ways that we can prevent spread of infection. And then also teaching the families about the signs of respiratory distress that we had talked about earlier because they need to recognize when their child may need more help. Strep throat is caused by group A beta hemolytic streptococcal bacteria, and a child who has strep throat is infectious from the onset of symptoms until he or she has received 24 hours worth of antibiotics. These children are at risk for developing rheumatic fever and acute glomerulonephritis, and that's one reason why we're going to educate them to take their antibiotics appropriately and the full amount to be taken. There are some children that are carriers of group A beta hemolytic strep, so that they are colonized with it. It exists in their throats, but they aren't sick from it. Diagnosis of this infection is done through using a throat culture and or a rapid strep test that both are obtained from swabbing the back of the throat to see if the bacteria is there. If the rapid strep test is positive, then you don't have to send the throat culture. However, if the rapid strep test is negative, we do send the throat culture because sometimes the culture grows out the bacteria that the rapid strep test did not detect. Treatment for this is an oral penicillin medication for at least 10 days. Usually what we give is amoxicillin, or if a child has a penicillin allergy, these children will receive penicillin. Once again, it's really important for the families to finish the full 10 days of antibiotics, and this will decrease the risk for developing the other diseases such as rheumatic fever and acute glomerulonephritis. So our nursing care includes medication administration education. Most children do not receive the medication in the way in which it was prescribed at home. Usually there's some sort of error. They get too much, they get too little, so we want to make sure that the parents know how to draw up the medication and provide it for their children. Pain control is important. These kids can have a sore throat, so we want to talk to the families about different ways to control their pain. I'm not talking about just supplying Tylenol or some sort of pain medication. There's also other things that we can do. Perhaps drinking a cold drink may help the throat feel better. Sometimes a warmer drink helps the throat feel better. Sometimes it could be a cool popsicle, an ice pop that might make them feel better. So there's other ways in which we could utilize to control pain. The one thing that is really important to stress is that these children cannot return to school until they have received a full 24 hours worth of antibiotics. So they should return within 24 hours of receiving antibiotics. We don't want to keep them out any longer because we don't want them to miss school, but they must stay out for 24 hours. The other thing that should happen is they should get a new toothbrush, because if they use the same toothbrush that had the bacteria on it, then it's just going to keep on reinfecting. So after 24 hours of antibiotics, the children can return to school, and they should receive a new toothbrush. The other thing we have to do at this time is wash any type of orthodontic appliances so that we get rid of the bacteria. We also need to educate the children to avoid sharing any objects, cups, any towels or anything. We want to make sure that we stress hand washing with them and that they understand that they need to do it all the time. And we want to discuss with the parents the signs of dehydration and also respiratory distress, because these two reasons will make the children have to come to the hospital in order to receive further care. So the next thing we're going to talk about is tonsillitis, and this is a common cause of illness in young children, and it does often occur with pharyngitis. It can be a viral or bacterial etiology. The clinical manifestations that we see in children are caused by inflammation that causes obstruction of the passage of air or food. We'll see difficulty swallowing. We may see difficulty breathing with children who have this inflammation. We also will probably see that the children will breathe through their mouth because it will be easier for them. The treatment is a tonsillectomy, which is a surgical removal of the palatine tonsils. Children also receive an adenoidectomy at the same time, which is surgical removal of the adenoids. So when you see it listed in the hospital, you'll see people talking about a TNA, which would be a tonsillectomy, and an adenoidectomy. So this is a picture that shows a child who has tonsillitis and pharyngitis. And if you look towards the back of the mouth, you're going to see the white plaques on the sides of the tonsils. So the tonsils are to the right and the left side. And you can also see some of the whiteness on the back of the throat. So the nursing care after surgery includes comforting, keeping the children comfortable, and pain management, and lots of rest. And we need to minimize bleeding. Bleeding is a big cause of complications after a tonsillectomy. So some of the things that we want to tell our children not to do is to avoid clearing their throat, avoid blowing their nose, and try to avoid coughing, because this may dislodge any type of clots that may have formed after surgery, and they might start having problems with bleeding again. We also have them eat a soft diet. That's going to feel more comfortable for them to eat. We're going to encourage cold drinks, ice pops, diluted fruit juices, but we don't want these to be red or brown in color, because then we won't know if this is blood or if it's the juice that they drank. We need to position them to drain their secretions, so this positioning could be side lying so that it can run out their mouth so that they're better able to expel it. And if we need to suction, we'll do this very carefully and very limitedly, because we really don't want to dislodge any of the clots that may have formed post-operatively. So education is a big thing with parents, teaching them about the signs and symptoms of bleeding. One of the things that we see when we with children who are bleeding is we're going to see them swallow a lot. So if you notice that the child seems to be swallowing a lot and it's not when they're eating or drinking, then we have to worry about that they are bleeding somewhere in their throat, and that needs to be evaluated. We also need to teach the parents about medication administration and rest, encouraging rest and a soft diet, so that they will follow the same directions when they're in the home. So influenza is known as the flu. It is caused by 3 different viruses, either type A, type B, or type C. This is spread through, these viruses are spread by direct contact with an individual or by articles that have been recently contaminated. And it is more common in the winter than in any other season. The incubation period is 1 to 3 days, and the affected person is most contagious within 24 hours before and after the onset of symptoms. So it's really easy to spread this virus because the person who is infected with the influenza virus is around people because they haven't had any symptoms yet, so that's during the time that they're most infectious and can spread it quite easily from person to person. So symptoms can last for 4 to 5 days. They may be subclinical to very severe. One of the things you can see is a dry throat and nasal mucosa. The children may have a dry cough, hoarseness, flushed face, photophobia, which is they do not like light, myalgia, hyperesthesia, exhaustion, lack of energy, and a sudden onset of fevers and chills. And one of the things that's fairly hallmark of the flu is that the symptoms really do come on pretty fast and furious, where the child will be well one day, start maybe feeling not so great that night, and then by morning they will be really sick. So there's different therapeutic managements. We can give them medications such as Tamiflu and Relenza that can decrease the symptoms and the duration of the symptoms, and we can sometimes prevent the disease in some people if we know they have been exposed. So Tamiflu is preferred over Relenza because Relenza can cause breathing problems and is not recommended for children who do. So oftentimes children receive Tamiflu. However, this does have side effects also. The side effects are nausea, vomiting, and mood and mental changes. But you need to start these medications within 2 days of the onset of symptoms, so it's really important to go see the healthcare provider early so that they can start this medication with the hope of lessening the symptoms duration and possibly prevent disease if we know that a child has been exposed. However, prevention is one of the best ways to treat the flu. So every child, every person should receive a flu vaccine every year beginning at 6 months of life. So the other thing we need to keep in mind is that sometimes children who have received the flu shot do end up with the flu. So it isn't prevention 100%, but what happens with these children is that their symptoms of the disease and the duration will be less severe than a child who has not received the vaccine. So when you're looking at nursing care for children with the flu, it really is the same as the other upper respiratory infections that we've talked about. So next we're going to talk about mononucleosis. This is an acute self-limiting infectious disease. It is caused by the Epstein-Barr virus, and it's transmitted in saliva, and this virus is viable for many hours outside the body. Mono has been also known as the kissing disease. So incubation is between 30 to 50 days, and the symptoms that you see are fever, exudative pharyngitis, lymphadenopathy, hepatosplenomegaly, and an increase in atypical lymphocytes on a CBC if you obtain a CBC in the child. So it's really important to identify this disease, especially because of the hepatosplenomegaly. Children who have a big liver and a big spleen have got to have limited activity because we can't take the chance of them falling or getting hurt and injuring those organs that are enlarged. So diagnosis is done via using the monospot or spot test, and what happens is these tests detect the antibodies, and they are also able to detect agglutinins at lower levels so that you can really obtain a diagnosis using these tests. There is no specific treatment, and the onset, type, severity, and duration of the symptoms vary greatly from child to child. Some children can have acute symptoms that disappear within 7 to 10 days, and sometimes we can see the fatigue especially be persistent and not subside until about 2 to 4 weeks. Some adolescents may need to restrict their activities for 2 to 3 months because of the fatigue and the hepatosplenomegaly. So antibiotics are contraindicated with mono unless the child presents with beta hemolytic strep or strep throat is present, and then we would treat that with the antibiotics, but not the mono virus itself. So the next grouping of diseases we are going to talk about are the croup diseases, and basically these are characterized by hoarseness and a barky cough with inspiratory stridor and respiratory distress, and all these symptoms result from the swelling or obstruction in the region of the larynx. In the United States, the majority of croup have a viral etiology, and the diseases that we see that go underneath this title grouping is acute epiglottitis, acute laryngotracheobronchitis, acute spasmodic laryngitis, and acute tracheitis. So with acute epiglottitis, what happens is there's an inflammatory process that causes an obstruction supraglottic, so it is above the glottis. This is a medical emergency. It is usually caused by the H. influenza bacteria. It is abrupt and rapid progressing symptoms that occur, and what you will see is the child sitting in a tripod position. So the child is sitting upright. He or she is leaning forward with the chin thrusted out and the neck extended. They're really trying to open up their airway to get air in. And the other thing you're going to see is excessive drooling, pain on swallowing, irritability, or an anxious look on the child's face, or a frightened expression because they are really having trouble getting air into their lungs. If you were to do a visual exam, what you would see is a large cherry red edematous epiglottis, but you should never examine the throat of a child that is suspected to have acute epiglottitis with a tongue depressor that's contraindicated until somebody is present who is able to intubate the child with a breathing tube or place a tracheostomy, because looking in there can cause complete obstruction of their airway. So you really need to have the personnel and emergency equipment ready. So never examine the throat of a child who you suspect to have acute epiglottitis. So this is a picture of a child who is in the tripod position. You can see that she is leaning forward, her neck is extended out, and she is really trying to open up her airway and get some air into her lungs. So this is a picture of epiglottitis. If that is the picture that is on the right side. So when you look at this picture on the left side, you can see that right here, this is where air enters into your lungs. These are the vocal cords here. So you can see that there is no swelling, where on this side, right here on the right-hand side, this is the acute cherry red inflammation, and this here, what you see, this tube here, this is actually a breathing tube that is going through the glottis and through the vocal cords into the lungs. Therapeutic management of children with acute epiglottitis really includes, it's very important to protect their airway. We need to ensure that they have a way in which to breathe. So they may end up with nasotracheal intubation or tracheostomy as needed if we can't keep it open. Humidified oxygen also helps keep oxygenate their body, plus the humidification can help with the swelling. These children will need to be placed on corticosteroids. This will help also manage the inflammation. And then they're going to receive 7 to 10 days of ceftriaxone. Ceftriaxone is the medication that will treat the infection. Usually what we see is that the swelling of the epiglottitis goes down after about 24 hours of antibiotics, so we'll see their respiratory status start to improve, and the epiglottis is near normal size by the 3rd day of antibiotics. So if the children are intubated, we should see them extubate at this time. The one thing we need to keep in mind is that when a child receives ceftriaxone, it may interfere with glucose testing. so that the glucose levels may not be normal. And this medication is also contraindicated with children who have bowel issues. But the healthcare provider will look at the benefits of providing the medication versus the risk. Family members of the child who has acute epiglottitis that have children that are less than 4 years old, or if the child with epiglottitis has had contact with any children who are less than 4 years old, these people will be treated with rifampin for 4 days to help decrease the spread of this infection. What we need to educate families about is that, especially adults, is that rifampin does decrease the effectiveness of oral contraception. So anybody who is taking that medication and is on any type of oral contraception should use an alternative form of contraception. And the other thing we need to educate our families about is that this medication can make your urine red or purple in color, as well as your sweat, your tears, and your sputum. And this is really important to let families know, because that would be kind of crazy and really scary to see your tears, your sweat, your urine, your sputum to be a red or purple color. So we need to educate them that this is a possibility. So nursing care really is around maintaining a patent airway, monitoring the respiratory status very closely. Depending upon the severity of the disease, the child could be NPO. We need to reassure the parents and reassure the child that over time they will get better. And we need to educate about the disease, and especially about vaccination with the HIV vaccine, because this will provide some protection against actually acquiring the disease. So this is a series of shots. It's usually a 3 or 4 dose series depending upon when the vaccine begins, or the type of vaccine, sorry, that is used, and this vaccine starts at 2 months of age. So next we're going to talk about infections of the lower airways, and this includes bronchitis, bronchiolitis, and pneumonia. So bronchitis is inflammation of the large airways, which would include your trachea and your bronchi, and it is frequently associated with upper respiratory infections. It's usually viral in nature. It's usually mild, self-limiting, and most children recover in 5 to 10 days. It can also be associated with an underlying condition, such as cystic fibrosis. Children with cystic fibrosis can develop bronchitis, as well as children that have bronchiectasis. So what we see with these children, they present with a dry, hacking, non-productive cough that worsens at night and becomes productive in 2 to 3 days. When we do see children, especially adolescents, who present with this type of cough, we also want to screen them for tobacco and marijuana use, because perhaps their cough is due to smoking cigarettes or smoking marijuana and not because of bronchitis. Bronchiolitis is also a common disease, and it is acute inflammatory injury of the bronchioles that is usually caused by a virus. Our most common viral cause of bronchiolitis is RSV, or respiratory syncytial virus. However, you can also see bronchiolitis with adenovirus, parainfluenza. We can also see the virus, but RSV is the most common and is transmitted from exposure from contaminated secretions that can live on objects for several hours and the hands for 30 minutes. The incubation period for this is 2 to 8 days, and identification of the virus is done by testing the nasopharyngeal secretions. And this is important to know, because you won't get a positive test for these viruses if you take a deep suction specimen. So this specimen that you use to test for these viruses is nasopharyngeal, or an NP secretion. So we just go into the nose with a culture, the culturette, the tip, the cotton tip, goes into the nose and touches the back of the throat, and that's how we diagnose this viral illness. So therapeutic management is to treat symptomatically. Some children will require oxygen when we do humidify the oxygen. Other children may be able to maintain their oxygenation status and may just be in the hospital because they're not able to maintain their airways. Children who have RSV especially have copious amounts of nasal drainage, so sometimes they have a very hard time keeping their airway clear. So airway maintenance is really important, frequent suctioning, but we want to be careful about suctioning because if we suction them with a suction catheter too much, we can cause swelling of the mucosa within their nose, thus decreasing the size too. So using a bulb syringe first is preferable. We want to make sure that the children are having adequate fluid intake. It's easy for them to get dehydrated. Some children may be NPO depending upon the severity of their disease and of their respiratory distress. Medications, sometimes children receive racemic epi, sometimes they receive ribavirin, and there's some question about whether bronchodilators help or not, so they may or may not receive these medications. So there are some high-risk groups of children who are at risk for developing severe disease if they get RSV. So these are children that have been born prematurely and have chronic lung disease, which is defined as going home on oxygen. These are children who have significant heart disease. These are children who have neuromuscular or congenital anomalies that impair their ability to clear their secretions. And these are also children with cystic fibrosis. So what we can do is we can provide them Synagist, which is an intramuscular injection. So we are actually providing them with the antibodies to protect themselves. So the next 3 slides describe the different children that receive Synagist and the determinations of the qualifications to receive this medication because it's very costly. I do not want you guys to memorize these different criteria for receiving it, but I do want you to know that what Synagist does and that it is provided to high-risk groups of children. So nursing care of these children really does surround around maintaining a patent airway, monitoring their respiratory status very closely so that we can diagnose respiratory distress quickly and give them the support that they need. We're going to monitor their oxygenation. They may or may not be NPO depending upon the severity of their disease. If there's groupings of children with RSV, we often cohort them together, or a nurse who is taking care of a child with RSV will not be taking care of a child who has some immunocompromise because we don't want to risk the possibility of transferring that disease. These children will be put on contact and droplet precaution, and we need to educate parents about the disease and also about how to keep their airways open through using nasal saline drops and suctioning. Next, we're going to talk about pneumonia, and what we see with pneumonia is an inflammation of the pulmonary parenchyma. Pneumonia can be a primary disease or a complication of another illness. The causative agent is either inhaled into the lungs or comes from a bloodstream infection. It can be viral, it can be because of a bacteria, it could be because of mycoplasma, or an aspiration of a foreign substance into the lungs. Pneumonitis is a localized acute infection of the lung, and what we don't see with pneumonitis is the toxic signs and symptoms that are associated with a lobar pneumonia. So pneumonitis is acute and localized inflammation without the signs and symptoms that we see with a lobar pneumonia. So the general signs and symptoms that we do see with pneumonia is a fever, usually pretty high. The children will have a cough, they'll be tachypnic. When we listen to the breath sounds, they will have rales and crackles because they do have wet lungs. And we'll also hear decreased aeration in their lungs, and we'll hear the decrease or even absent aeration, especially in the areas of consolidation where the pneumonia is located. When we percuss their lungs, we'll hear a dullness. They may have chest pains, respiratory distress signs such as retractions and nasal flaring. They may be pale or they may have cyanosis. They may be irritable, restless because of their inability to breathe effectively. They may have malaise, anorexia, vomiting, diarrhea, and abdominal pain. So it's really important to recognize these signs and symptoms sooner so that we can help open up their lungs quicker so that they can breathe more comfortably. Pneumonia that's caused by a virus is more common than a pneumonia caused by a bacteria. Viral infections of the respiratory tract do make the child more susceptible to a secondary bacterial infection. Strep pneumoniae is the most common bacterial pathogen that we see with pneumonia, and we can prevent this from happening by having children receive the pneumococcal conjugate vaccine. So complications of pneumonia can include an acute otitis media, pleural effusions, empyema, pyeloneumothorax, which is a pneumothorax that has pus in it instead of air, or you can also see a tension pneumothorax. So when we look at a child's chest x-ray, what we see is diffuse or patchy infiltrates in the affected lung field. So when you look at an x-ray, a normal x-ray, what you should see is just the rib cage with dark black in between, because the air, whenever there's air on an x-ray, it looks black. So what we see with these children are areas that have whiteness in it, and this whiteness represents the pneumonia. So nursing care really does emphasize promoting oxygenation. So we may be delivering children oxygen through nasal cannula, or we may be doing breathing exercises with them to encourage them to take deep breaths and blow out so that we can help open up their lungs. There's many different ways that we can do that with children. With adults, we tend to use incentive spirometers, but with children, especially younger children who may not understand how to use incentive spirometers, what we'll use is bubbles. And so we'll bring in a bottle of bubbles and we have them take a deep breath in, and then we have them blow out and blow the bubbles so that they're doing the same breathing exercises, but they think it's fun because they're blowing bubbles. We need to monitor their respiratory status very closely to watch out that they don't have developed severe respiratory distress, that we support them before that time. We're going to promote comfort, rest, fever management, strict I's and O's. We really need to make sure that they don't become dehydrated. If it is a bacterial pneumonia, then we will treat them with an antibiotic. If it's viral, then antibiotics aren't indicated. We're going to support the family. And if there are complications, the children may receive pleural taps or chest tubes. So they may put a needle into the lungs to drain fluid or to drain air, or they can put a chest tube that stays in there to drain it continuously. Next, we're going to talk about foreign body aspiration. And this can happen at any age, but is most common in children that are 1 to 3 years of age. So we have to be really careful with these children not to leave small objects or food around that they can potentially aspirate. The severity of disease is determined by the location, the type of object that the child has aspirated, and the extent that this object is obstructing their airways. There are some offending foods that we see, which are hot dogs, round candies, peanuts and other nuts, grapes, cookies, or biscuits, meats, caramels, carrots, peas, apples. So there's a lot of different offenders. So one of the reasons why Lifesavers is called a lifesaver is because when you look at it, remember it's not a solid piece of candy. So if a child was to aspirate a lifesaver, there would still be a way in which air could pass through because it's not a solid candy. There are also other items that we see that children can aspirate, such as paper clips, small magnets, latex balloons. That's why latex balloons aren't allowed in hospitals anymore. Either plastic or glass beads, marbles, pen or marker caps, buttons, batteries, coins, small toys. There's a lot of things that children can aspirate from. So the clinical manifestations we usually see with children is that they're choking or gagging or wheezing, coughing, having trouble breathing, stridor, hoarseness, or they may indeed be completely asymptomatic. What happens is we get a chest x-ray, and on the chest x-ray we see the object, but doing endoscopy is both definitive diagnosis and treatment, so sometimes they have to go in and confirm what we're seeing, and then through endoscopy they grab the object and take it out. So these two x-rays represent children who have swallowed coins. So you can see that on the left-hand side, the coin is lodged in the child's throat. And if you look at the x-ray on the right-hand side, the coin has gotten a little bit further, so it's actually down into the lungs right at the bifurcation where the large airway bifurcates to the separate lungs. This next slide is induced a little bit with color, but this is a picture of a child who aspirated a Lego. So that, of course, they didn't see this red Lego. They have put color to this, but you can see how the side of the lung in which the Lego is in, it is much bigger, so we call that hyperinflated from the opposite side. And this, if you can see it, is a picture of a safety pin. So once again, this is the epiglottis and the vocal cords, and right underneath of that is the head of a safety pin. So this is a child had swallowed a safety pin. And you can also see, if you look closely at it, that the safety pin isn't closed, so they actually have swallowed an open pin that will have the sharp side sticking out. So the nursing care with a child who may have aspirated an object is to not make any blind sweeps of the mouth because you might push the object down quicker. So remember, we only sweep for objects that we can see. We don't sweep just to see if we can catch something. We need to make sure that we recognize respiratory distress in these children, maintain an open airway and oxygenation, and then our education should be geared towards prevention of choking and having small objects that a child can aspirate either from eating or from placing them into their own mouth. So next we're going to talk about asthma, and asthma is a chronic inflammatory disorder of the airways characterized by recurrent symptoms such as wheezing, breathlessness, chest tightness, and coughing, airway obstruction, and bronchial hyperresponsiveness. It is the most common chronic disease of childhood. The onset can happen at any age, but 80 to 90% of children who have asthma have their first symptom before they are 4 to 5 years of life. Early in life, we see it affecting boys more so than girls, and then once we get to adolescence, we see it affecting girls more so than boys. And the prevalence of asthma is increasing in the United States, especially among our children of African American descent. So these diagrams here are depicting what occurs within the lung and the airways of a child with asthma. So figure A to the left-hand side depicts a normal lung, and you can see that the airways, the tubes are open, clear, and there's no type of secretions anywhere. But then when you look at the right side, which is labeled B, what you can see with the asthma attack is that you have thick mucus, the mucosal is swollen, and the smooth muscle is also spasmed. So what that causes is constriction or obstruction of the small airways, and it is very difficult for children to breathe. It's very labored breathing and very difficult breathing because their airway is really much smaller than you see on the picture on the left-hand side. So there are 4 different categories of asthma, and you do not have to memorize these categories and know the signs and symptoms underneath them. But what you do need to know is that as the categories, the asthma become more severe, then the symptoms occur more frequently. You see them more so also at nighttime, that when we look at their pulmonary function, it is decreasing, and having asthma does interfere with their normal activity more, and they have to utilize their rescue medications or their short-acting beta agonists for symptom control more frequently as their asthma is in a more severe category. So therapeutic management of children with asthma, really the goal is to maintain normal activity levels, normal pulmonary functioning. We want to prevent the chronic symptoms and recurrent of exacerbations, and we want to optimize their drug therapy with minimal or no adverse side effects. So no matter what medication we give, there are potential for side effects, so we want to use the least amount of medication so that we can have the least amount of adverse effects. And allergen control is really important for a lot of these kids. Allergies can cause an exacerbation to come. So allergy control includes encasing their pillows, their comforters, their bedding, because that's where you spend a lot of your time is sleeping. So that can help decrease asthma exacerbations. If the child has some sort of allergy, especially to pets, then what we have to do is eliminate the pets from the household, or really clean and vacuum frequently so that they don't have trouble from the hair. So allergen control is also very important with therapeutic management. Drug therapy is also very important to our children, but remember that there are different types of medication treatment. So we have our long-term medications that are preventative, and our quick relief medications that we give for a rescue. Oftentimes, the quick relief medication and long-term medications are used in combination. But what we have to keep in mind is that if a child is having an acute exacerbation is having an asthma attack, the medication that they're going to use is oftentimes their short-acting beta agonist, which is albuterol, Xopenex, or terbutaline. That is what they're going to use for rescue and relief. They won't be using their long-term control medications for relief because that won't act quick enough to relieve their bronchospasm. So the hallmark of treatment really does surround around decreasing the inflammation. We can decrease inflammation by using inhaled corticosteroids. The inhaled corticosteroids that we use are besetamide and fluconazole. So they are the 2 medications that we use for inhaled steroids to decrease inflammation. Keep in mind that when we administer these medications, we have to remember to encourage the children to rinse out their mouth with warm water after they take the medicine, so that we decrease the possibility of them developing a yeast infection within their mouth. The other thing that we have to remember too is that children also, from a preventative standpoint, are oftentimes put on a leukotriene modifier, better known as Singular. A lot of kids are placed on Singular, and the Singular, when they take it, they take that medication at night. So we do have to educate our parents about doing that. So our quick relief medications, we can give them via inhalation using a nebulizer or a metered dose inhaler. That can be with or without a spacer. We talked about that during our on-campus clinical time, and you got to use them. So keep in mind that a nebulizer administers the medications better and is more effective than using our metered dose inhalers. So if a child's really having trouble breathing, we're going to put the nebulizer on her as opposed to using an MDI unless the MDI is the only thing that we have in our possession at the time. So when a child has status asthmaticus, this is a medical emergency. It can result in respiratory failure and death if it goes untreated. What happens here is that you have persistent symptoms despite vigorous treatment. Emergency treatment of children with this type of attack is giving them epinephrine subcutaneously. Our goal with these children are to improve their ventilation, oxygenation, and decrease the airway resistance, and relieving the bronchospasm is our goal. So we will be using different medications to establish to achieve these goals. So this is a picture of a child who is using his MDI, his multi-dose inhaler, with the spacer. He is also utilizing a face mask. A face mask is important for children who are younger because they can then take their breath through both their nose and the mouth. When you don't have a mask and you just use the mouthpiece, then you have to make sure that the child is breathing in and out of their mouth in order to receive the medication into their lungs. This is a picture of a child who is getting a nebulizer treatment using the mouthpiece. It's really important when you use this type of nebulizer using the mouthpiece that the child breathes both in and out of their mouth and not their nose. So you should see the smoke on the end going in and out so that we can know that they are breathing through their mouth so that the medication will get into their lungs and not through their nose. And this is a picture of the nebulizer via mask. With the mask, the child doesn't have to just breathe through their mouth. They can breathe through both their mouth and their nose. So it's oftentimes a little easier for children to use the mask, but they don't oftentimes like to because it makes their face really wet, and the medication also smells a little funny to them, so they sometimes don't like to use the mask. So nursing care really does evolve around educating how to avoid exacerbation, how to avoid allergens, and to utilize their rescue medications promptly to relieve any type of asthmatic episode, also to relieve the bronchospasm. They're going to follow their pulmonary function using a peak flow meter, and also educate them with self-management of inhalers, the different devices, and activity regulation. That's when they're having an attack. They don't need to have decreased activity otherwise. And also medication administration. We want to make sure they know which medications to take when, which are your rescue meds, which are their long-term meds, and proper way in which to take them. Every child should have an asthma action plan. I have posted an asthma action plan on the Blackboard website for you to look at. This describes to the children the green zone, which is feeling good, and what medications, if any, they should be taking that. When they enter into the yellow zone, what symptoms that represents and what they should do for the time so that they don't end up in the red zone, which is a very symptomatic, they're having an acute exacerbation at that time and what they need to do. But it does give the family and child details about the symptoms and what they should do to relieve them. So now we're going to talk about cystic fibrosis, or CF as a lot of people refer to it. Children that have CF do have exocrine gland dysfunction that produces multi-system involvement, and we're going to talk about each system that is involved with these children. It is the most common lethal genetic illness among Caucasian children. It is autosomal recessive, which means that the child inherits the defective gene from both of their children, and overall it affects 1 in 4 children is its incidence. There are approximately 3% of Caucasians in the United States that are carriers and are symptom-free. So this table, this schemata really does describe what happens with cystic fibrosis. So you have the basic gene defect, which causes exocrine gland dysfunction. And what happens here is there is abnormal mucus secretion, which can cause obstruction. So in the bronchi, you have very thick, tenacious secretions, which can cause bronchial obstruction. And when you have bronchial obstruction, what can happen from this is chronic bronchial pneumonia or a generalized obstructive emphysema because there's air trapping that occurs within the lungs. What can happen in the small intestine that we see with these children, usually at birth, it's one of the first signs and symptoms that we see of cystic fibrosis, that they may have a meconium plug. So because of the thick tenacious secretions, we see intestinal obstruction. And then when we test further, once we've found this in a newborn, we then test for cystic fibrosis. The next thing that we can see with their pancreatic ducts is that because of the secretions and the mucus and the obstruction, we can have secondary degeneration of the pancreas, which then causes a malabsorption syndrome because the children don't have the pancreatic enzymes that they need to digest their foods well. And then in the biliary ducts, we can see focal biliary fibrosis, and which causes biliary cirrhosis, and ultimately these children can develop portal hypertension. So CF is characterized by several clinical features. As I talked about before, there's increased viscosity of their mucus gland secretions, so their secretions are very thick and tenacious, and these secretions are what's responsible for many of the clinical manifestations. We also see an elevation of sweat electrolytes. So what we see is an increase in the sodium and chloride content in both their saliva and their sweat. And we will also see some abnormalities of the children's autonomic nervous system. As we talked about before with the diagram, they do have pancreatic enzyme deficiency. So this affects their ability to digest their foods. They do develop progressive chronic obstructive pulmonary disease, and this is also associated with infection. They do have many lung infections. They have sweat gland dysfunction. They are oftentimes failure to thrive because of their inability to get good nutrition and be able to absorb the nutrients. They may have increased weight loss despite increase in their appetite, and gradually over time these children do have respiratory deterioration. So children nowadays do live into adulthood. When I first started in nursing, it was unlikely for a child to make it to his teenage years, let alone into adulthood. So we really are doing better with supporting and being able to help these children have a fuller life. So clinical presentation can include wheezing, respiration, a dry, non-productive cough, a generalized obstructive emphysema, patchy atelectasis on their x-ray because of the thick, tenacious secretions that can plug their airways. They can be cyanotic. They can have clubbing of their finger and toes. You may see repeated bouts of bronchitis and pneumonia. At birth, as I talked about before, they may have a meconium ileus or a meconium plug, and this is usually the earliest signs that we see of cystic fibrosis. And then we also may see them present with a prolapse of their rectum due to obstruction within their bowel. So they also might have intestinal obstruction syndrome due to the thickness of the secretions. Once again, they will have stool that is bulky, frothy, and foul-smelling. That has to do with their inability to digest fat. Also, if you looked at them in the toilet, they would float because they have a lot of fat content. They have wasting of their tissues. We'll see delayed puberty in females. sterility in males that has to do with the thick secretions and the inability of the sperm to be able to move within the thick secretions. Parents often report that their children taste salty. Remember that they have an increased amount of sodium and chloride secretions within their sweat. They can become dehydrated. We can see hyponatremic or hypochloremic alkalosis because of their inability to hold on to those electrolytes, and we also may see hypoalbuminemia because of their inability to digest proteins. So diagnostic evaluation is via a quantitative sweat chloride test. So basically what we do is we heat up an area of the child's forearm and we actually cause it to sweat, and we collect the sweat, and then we measure the amount of sodium that is within the sweat. So we cannot sweat children. Newborns cannot get a sweat test until they're a little bit older, so we don't oftentimes have definitive diagnosis until they are older because it's really hard to get a newborn to sweat, so they have to be in infancy in order to do that. We also may see pneumonia and different lung changes on chest x-ray. We can do pulmonary function tests to see how good their pulmonary function is. We can look at their stool for fat or enzyme analysis to diagnosis, and we also can utilize barium enema. What we're diagnosing there is the meconium ileus or plug. It is diagnostic and also usually therapeutic because it helps relieve that obstruction. So respiratory manifestations are usually present in almost all children with cystic fibrosis, but the onset and the severity of the symptoms do vary because of the really viscous secretions, and it's difficult for them to get rid of them, that we do see obstruction of the bronchi and the bronchioles that causes atelectasis, so closing down of the areas, the alveoli in the lungs. That is where air exchange happens. And also we can have hyperinflation because of air trapping, because the air then gets into those areas but isn't able to get out. The stagnant mucus can lead to destruction of the lung tissues, as well as create a favorable environment for bacteria to grow, and that's why these children do have chronic infections. So this is a list of the most common infectious pathogens for children who have cystic fibrosis. So the respiratory progression is usually gradual and follows chronic infection. What happens is the bronchial epithelium is destroyed, infection spreads to the peribronchial tissues, weakening the bronchial walls and developing peribronchial fibrosis. You'll see a decrease in the exchange of both oxygen and carbon dioxide in these children, and their chronic hypoxemia, their chronic decrease in their oxygenation, causes contraction and hypertrophy of the muscle fibers of the pulmonary arteries and arterioles, causing pulmonary hypertension, cor pulmonale, because of the destruction of the air tissues. You may see a pneumothorax, and you can also see hemoptysis in these children. So from a gastrointestinal standpoint, the GI progression is that we see thick secretions that block the ducts, that leads to cystic dilatation, degeneration, and diffuse fibrosis. There is prevention of the pancreatic enzymes from reaching the duodenum, and it causes impaired digestion and absorption of fats, or steatorrhea, your fatty stools occurs. You also have decreased or impaired absorption and digestion of proteins. And initially, from an endocrine standpoint, the pancreas is unchanged, but eventually over time what happens is the pancreas becomes fibrosed, and the result oftentimes occurs in the children developing diabetes mellitus. You can also have focal biliary obstruction that results in multilobar biliary cirrhosis, and then these children can also have impaired salivation. So this can affect also their digestion, because remember, in your mouth, your saliva starts breaking down the food, so that the inability to utilize nutrients will start right away with consumption. So the treatment goals for children with cystic fibrosis really is to prevent or minimize your pulmonary complications, to give adequate nutrition for growth. So these children need really high calories, and they also need a lot of sodium intake because they're sodium wasters. So they get rid of a lot of sodium. So these are the kids that you allow to use the salt and use as much salt out of the shaker that they want. The other thing that we have to do is help our children adapt to having a chronic illness and living with this illness and having the best quality of life that they can have. So respiratory management of these children include chest physiotherapy or CPT and postural drainage. These children will receive a bronchodilator medication. They will do exercises for forced expiration to help with their lung aeration and mechanics. They will get aggressive treatment of any pulmonary infections utilizing home IV antibiotics with a percutaneous central line or a PICC line, and also may receive aerosolized antibiotics. We want to prevent possible complications such as pneumothorax, hemoptysis. These children will have nasal polyps. They will most likely be on and off a steroid treatment or may also receive non-steroidal anti-inflammatory drugs to help them. And then ultimately, there is a possibility of receiving transplantation if their lungs really are failing. But remember that that's not going to change the disease process. It's just going to give them a new set of lungs, but they will still make thick, tenacious secretions that will then start the cycle of destroying their new lungs. So this is a picture of a child receiving chest physiotherapy. You can see that he has a vest on, and that vest is causing the vibrations in the lungs. The idea is to help loosen up the thick secretions so that the child can cough the secretions up. So it is a good sign if the children are able to cough the thick mucus secretions up and expel them. You can also deliver chest PT by using your hands in a cupping way and hitting on the different areas of the back of the lungs, but the vest is what is used conventionally nowadays. So the GI management of these children includes replacement of their pancreatic enzyme. So they will receive a medication that will replace their lipase, amylase, and protease enzymes. They receive the enzyme supplementations prior to a meal and prior to eating. Depending upon whether they're eating a meal or a snack will depend upon how many of the pancreatic enzyme replacement pills that they will take. These children need a high protein, high calorie diet, and they will take in as much as 150% of the recommended daily allowances for diets of children that are of similar age. We need to treat their constipation. That will reduce the possibility of developing rectal prolapse. These kids, as I said before, are salt wasters, so that we encourage salt supplementation. They can use and are encouraged to use as much salt as possible and to consume salty snacks. And if the child does have gastrointestinal reflux, we're going to place the child in an upright position after meals to help treat this. So the endocrine management includes monitoring their blood glucose levels. We are going to be on the alert of these children possibly developing high glucose levels and requiring treatment. We're also going to monitor their diet. Remember, we're going to encourage the high protein, high calorie diet. We want to encourage them to exercise and to get regular eye examinations to make sure that their eyes are developing properly and there's no problems there, especially if they have high glucose levels. So as I said before, life expectancy is a lot better than it had been before. So in 2008, the life expectancy for a child who was born with CF was to about 37 years of life. That may seem young, but it is much older than what it used to be. As I said before, these children really didn't see their teenage years or much of it prior. But it does continue to be a progressive, incurable disease. Organ transplantation has increased the survival rate. So you can get a heart-lung bypass and a bilateral lung transplantation. Some children have also received liver and pancreas transplantation. So what we want to do is maximize their health potential through good nutrition, prevention and early aggressive treatment of any infection, and good pulmonary hygiene through using their medications, their chest PT, the vest, and doing postural drainage to help facilitate excretion of those thick secretions within their lungs. So nursing care really is education of the treatments, of medication administration. We want to help the families to cope with the emotional needs of having a chronically ill child. The child will require frequent treatments multiple times a day, so we have to help them figure out how to accomplish that. These children will frequently be in and out of the hospital, so we need to help support patients, children, and family with that. And also we need to educate about the implications of genetic transmission, because especially if this is their first child, the parents may decide perhaps not to have another child, especially if the type of cystic fibrosis they have is a more lethal type. There are different types of cystic fibrosis, there's multiple types, and the different mutations do have more and less severe presentations and disease progression. So next we're going to talk about sudden infant death syndrome, or SIDS, and this is sudden death of an infant younger than 1 year of age that remains unexplained after complete post-mortem examination, including investigation of the death scene and a review of the case history. So typically SIDS occurs unwitnessed. It typically occurs during sleep or in transition between sleep and arousal. It's the second leading cause of postneonatal mortality and the fourth leading cause of infant mortality in the United States, according to the National Vital Statistics Report for 2014. SIDS affects boys more so than girls. There's also a higher incidence in Black, American Indian, and Native Alaskan children. There is decreased incidence after we have put some safety into effect. So the American Academy of Pediatrics do recommend children to sleep in a non-prone position, and that started in 1992. And in 1994 is when they first instituted the Back to Sleep campaign. So where we encourage children to sleep on their back and not on their belly, and we definitely saw a decreased incidence after instituting these policies. Then in 2016, we added some more recommendations, and basically what was recommended that infants should sleep in the parents' rooms, close to the parents' bed, but on a separate surface that is designed specifically for infants, ideally for the first year of life, but at least for the first 6 months of life. And so this is also a recommendation that has been made by the American Academy of Pediatrics as part of the Back to Sleep campaign. There is an increased incidence in other sleep-related infants' deaths, such as accidental suffocation and strangulation that we have seen with children, but we have definitely seen a decreased incidence in SIDS since we've instituted this type of program and education. So the exact cause of SIDS remains unknown. We do believe that there's some intrinsic features and some extrinsic features. So intrinsically, we think that there may be some sort of brainstem abnormality in the neurologic regulation of their cardiorespiratory control that affects arousal and physiologic responses to life-threatening or challenges during sleep. So if perhaps the child stops breathing, usually as CO2 increases in your body, that stimulates the brain so that the child or person starts breathing and starts breathing faster to get rid of the CO2. And we think that there's something wrong with those connections, that it may not be happening. There's also some extrinsic features, such as their sleep environment and sleeping positioning. So that's why we discourage any type of soft bedding, soft objects, and we also discourage sleeping on their belly so that there isn't any potential for suffocation. We do know, though, that there are certain risk factors that we see in children who have SIDS. So maternal smoking during pregnancy, exposure prenatally to alcohol and drugs, co-sleeping, prone sleep position, soft bedding, respiratory or gastrointestinal infections, possibly low birth weight, and then there's some question about siblings. So if you have 2 or more siblings that have suffered from SIDS, there's a potential to increase your risk for developing SIDS. So as we had talked about before, there are recommendations for prevention. So sleeping supine on a firm surface, room sharing without bed sharing, no soft objects or loose bedding, regular prenatal care, avoiding smoking, alcohol, and illicit drugs, breastfeeding your baby. There's research that shows that children who sleep with a pacifier, especially less than 6 months, have a decreased risk for SIDS. Avoid overheating, immunize the infants, and avoidance of commercial devices to prevent SIDS. So there's different types of positioners, wedges, special mattresses that we want to recommend them to avoid. Now, children do need to have some tummy time, so they do need to be prone, but this time needs to be supervised, which means somebody has to be with the neonate or baby and observing this while it's happening. And nursing care includes education once again, and education is the key. Education begins during pregnancy and continues through the first year of the infant's life. And then the other nursing care we provide is support of the grieving parents and family who have lost their child to SIDS. So now we're going to talk about brief, resolved, unexplained events, or BRUI, which you still may hear in the hospital called an ALTI, or an acute life-threatening event, because that was the old term that we used to call it. So what this is an event that occurs in an infant younger than 1 year, and when it has been observed, what happens is the observer reports a sudden, brief, and then resolved episode of at least one or more of the following signs. So either cyanosis or pallor, absent, decrease, or irregular breathing, a marked change in tone, and usually we see hypotonia or decreased tone, and an altered level of responsiveness. So a BRUI is very different from SIDS, but we do see a common risk factor between both SIDS and BRUI, and that is maternal smoking. And there is some thought that as the risk for SIDS increases, these children have had, the risk of SIDS increases 3 to 5 times in children who have had a brief, resolved, unexplained event. So it's really important to get a detailed description of the event. So whoever has observed it, we need to see and learn and have them describe what they actually saw happen with the baby. We need to get a detailed prenatal and postnatal history. And then we need to evaluate the child for some underlying disease. Sometimes seizures present with apneic episodes, so we need to rule out apnea. We need to rule out gastrointestinal reflux. Respiratory conditions such as infection, periodic breathing, and apnea, any type of metabolic condition, especially our inborn errors of metabolism. We'll talk about all these later in the course. Any type of cardiac anomaly or arrhythmia, And then also we need to investigate for child abuse, because sometimes that is the reason for this unexplained event. So the workup that we get is to rule out a lot of these potential other problems. So we get a chest x-ray to look at their lungs. We get an ECG to look at their heart rate and rhythm for any abnormalities. We will get an arterial blood gas to look at their ability to exchange oxygen and CO2, and also to see if there's any acidosis present. We'll get a complete blood cell count, electrolytes, magnesium, lactate, pyruvate, and ammonia. We get them to rule out our different metabolic disorders. And then we will also look at their urine, do a urinalysis and a urine for toxicology to make sure that there are no type of drugs or different sorts of substances within their urine. So management really does include observation. These children will be admitted to the hospital and observed to see if any events occur again. Some children may be sent home on a home apnea monitor. Other children may not. The value of having a home apnea monitor is unclear, although if they do have an increased risk for SIDS, this may possibly alert the parents, but there is it's not really known whether it would help prevent it from occurring or not. And then nursing care really evolves around education and support of these families so that they know to watch and how to support their child, and to give potentially rescue breathing, CPR to their child if needed. So this is a picture of a home apnea monitor. What happens is that there are probes that are on the belt around the chest that will pick up the electrical impulses, both the respiratory rate and the electrical impulses will pick up the heart rate. And then if the monitor perceives that the respiratory effort has decreased for greater than 20 seconds, then the monitor will go off. So this monitor is awfully loud. It's really hard to sleep through. So basically the alarms are set at a certain heart rate, and the length of time that can go in between breaths is 20 seconds or less than 20 seconds. Once it's 20 seconds or more, then it will alarm. So next we're going to talk about alterations in ear and eye functioning in children. So we're going to talk first about otitis media. And otitis media is a very prevalent disease that we see in children, especially in the earlier years. Otitis media is an inflammation of the middle ear without reference to etiology or pathogenesis. So acute otitis media is an inflammation of the middle ear space with a rapid onset of signs and symptoms of the acute infection, and usually what we see the complaint of is fever and ear pain. You can have otitis media with effusion, so basically there is fluid in the middle ear space without symptoms of acute infection. So you can have otitis media present as an acute otitis media where there is fever and ear pain, or you can have it present where you just see fluid in the middle of the ear, but the child doesn't have any signs and symptoms of an acute infection. And otitis media is a result of malfunctioning of the eustachian tubes. So otitis media is one of the most prevalent diseases in early childhood. It is highest in the winter months. Most are bacterial. Most of our bacterial otitis media are preceded by a viral infection. Most commonly we see RSV and influenza. The most common bacteria of acute otitis media are Staphylococcus pneumoniae and H. influenza. And the etiology of non-infectious otitis media is unknown. So you can have chronic otitis media, and there's certain criteria that you have to meet to be considered chronic. So if you have 3 infections in 6 months, 6 in 12 months, or 6 infections by the age of 6, then you are considered to have chronic recurrent otitis media. There are some predisposing factors that we see with children who develop otitis media. So they are respiratory, children who have had respiratory, upper respiratory infections, who have allergies, who have Down syndrome, who have a cleft palate. We'll talk more about that later. Daycare attendance, exposure to secondhand smoke, parents engage in propping the bottles during feedings, and also we see an increased incidence of children who are formula fed. So prevention is the key. We have seen a decrease in otitis media since we have started providing the pneumococcal conjugate vaccine. This is a 4-dose series that begins at the age of 2. Breastfeeding should also be encouraged in general, but we see a decreased incidence of otitis media in children who have received breast milk. We want to educate the parents to avoid propping bottles. We're going to ask them to decrease or discontinue use of pacifiers after 6 months, and also avoid exposing the child to tobacco smoke. So clinical manifestations of otitis media include earaches, possibly fever. Sometimes you might see purulent drainage. The child may be crying, very fussy, irritable, have a tendency to rub, hold, or pull on the affected ear. These children may have a loss of appetite and refuse to eat. You might see them rolling their head from side to side, especially a young infant or child. You might have difficulty comforting the child. You may see that the children don't seem to be hearing or may not be making language, saying words in the language that we think that they should. And also, because of not being able to hear the words, they have difficulty with communication. Remember that otitis media often follows an upper respiratory infection, so you may see clinical manifestations of that also. So there are complications of otitis media, especially if it does not get treated or treated completely. That's why it's very important for us to stress to the parents that they need to complete all of the antibiotics that are provided. So the complications can include mastoiditis, facial nerve paralysis, brain abscess, labyrinthosis, hearing loss, and communication and speech difficulties. So this is a picture of a normal eardrum that is on the left-hand side, and you can see that this is not red in color. When you look at the right-hand side, what you can see is that there's an acute otitis media, and you can see that the eardrum is a little bulgy, that it is red in color, and if you look really closely at it, you can see a little bit of fluid accumulation. So this slide is depicting what otitis media with effusion looks like. So once again, the circle that is all the way to the left shows the normal eardrum. When you look at the middle circle, that's showing some fluid, so you can see the air fluid levels, so that looks like bubbles inside the eardrum. And then when you look at the extreme right side, what you see is an effusion, so this is a eardrum that is full of fluid. But remember that this looks different than the one we saw earlier because there's no redness. So it will be red with an acute otitis media. So management of otitis media is dependent on the age of the child. If the child is less than 6 months of age, then all children receive antibiotics. If the child is greater than 6 months of age, we usually wait 72 hours for a spontaneous resolution of the otitis media. If a child is less than 2 years of age with persistent acute symptoms such as fever and ear pain, then we provide them with antibiotics. And we also have to do intermittent hearing testing, especially for children who have had chronic infection, because we want to ensure that they are able to hear, and because not being able to hear will affect their speech. So we want to make sure that we check their hearing along the way. So treatment for for otitis media includes antibiotic treatment. Our first line treatment is amoxicillin. We use this for the initial episodes of otitis media in children who have not received antibiotics within the past month. The dosing is 80 to 90 milligrams per kilo per day, divided twice a day. And we provide the antibiotics for 5 to 7 days for a mild or moderate infection, and for a severe infection we give it for 10 to 14 days. And once again, it's really important to stress to the parents that they must complete all the antibiotics that we provide to them. The next treatment that we use is Augmentin. Augmentin is a combo drug of amoxicillin and clavulanic, and this is our second line of antibiotic treatment. And we may try amoxicillin first, and then if that doesn't cure the symptoms, move on to Augmentin, which is a stronger medication. And then our third line of antibiotic treatment is our cephalosporins, and that is our stronger treatment. So that isn't our first, as in our initial treatment, but we use that as our third line antibiotic treatment. Remember that with all these antibiotics, there are potential side effects. Children can develop diarrhea, especially from these different treatments, because remember that the antibiotic will treat also the bacteria that's inside the bowel, so it's not uncommon to see diarrhea in children. There is also surgical treatment in children who have chronic otitis media. So what they do is a myringotomy, or they make a surgical incision on the eardrum. This is to alleviate severe pain, drain any infected middle ear fluid, and to allow purulent fluid to drain into the ear canal. And you can also culture any fluid that drains into the ear canal. The other type of treatment is through tympanostomy tube placements. So these are the ear tubes you hear a lot of people talk about. And this is used to treat chronic otitis media, severe eustachian tube dysfunction, or otitis media with infusion or complications of otitis media. So what these tubes do is they are pressure equalizer tubes that facilitate drainage of the fluid within the ear and allow for ventilation of the middle ear. These tubes can fall out, so sometimes you can see that they fall out onto the bed, onto the pillow of the child. So nursing care does depend upon why the child is hospitalized. Most children do not get hospitalized for otitis media or tube placement, but we are going to try and relieve the pain. If there is any type of drainage, we want to help facilitate that. We can place some sort of loose gauze or loose cotton within the ear to help catch the drainage if there's any drainage, cleaning of the ear, and also putting a barrier protection to protect the skin so it doesn't start to break down. Prevention of complications or recurrence is education that we can provide to the parents, especially reducing the risk factors. We want to educate on medication administration, fever management, and keeping water out of their ear, and of course, as always, supporting both the child and the family. So otitis externa is different than otitis media because this is inflammation or infection of the external auditory canal, the auricle, or both. This is very commonly known as swimmer's ear. So what we see on physical exam, that these children have pain when we are palpating the tragus or application of traction to the pinna. It's most oftenly caused by a bacteria, but can also be from a fungus. So there are certain risk factors that predispose children to this. So if there is absence of cerumen or wax, high humidity, retained water in the ear canal, increase in temperature, or local trauma, especially from use of cotton swabs or hearing aids, it can increase the children's risk to developing otitis externa. So this is a picture of what otitis externa looks like and the inflammation outside of the ear. So management depends upon the etiology. If it isn't a bacterial infection, then we're going to administer ear drops, which can be 2% acetic acid with or without hydrocortisone. The child will get 4 drops in the affected ear 4 times a day for 7 days, or ciprofloxacin and hydrocortisone 3 drops in the affected ear twice a day for 7 days, or neomycin polymyxin B with hydrocortisone 4 drops in the ear 3 times a day or 4 times a day for 10 days, and so on. So the best management with children is to give medicine the least amount of times per day. That will be the most successful management. So oftentimes, especially with a younger child, we will pick a treatment that is less times a day so that the parents can more successfully treat the ear. And if it's a fungal infection, then we have to treat that infection with an antifungal agent such as clotrimazole, 1% drops in the ear. So nursing education is important. Once again, medication administration, teaching the parents how to administer ear drops. Remember that for children less than 3, we need to pull the ear down and back. When they are older, we pull the ear up and back. We want to keep the ear dry. We want to avoid Q-tip use and preventative treatment with acidifying drops so that the inside of the ear, that part of the ear, doesn't get kept wet. Next, we're going to talk about conjunctivitis, and conjunctivitis is inflammation of the conjunctiva. It is caused by bacterial, viruses, allergic reaction, and foreign bodies, and the treatment does depend upon the cause. Viral conjunctivitis is self-limiting and only includes removal of the secretions. Bacterial conjunctivitis is usually treated with antibiotic drops or ointments, and for both or any of these conjunctivitis, we can use warm, moist compresses to wipe the secretions, but we always want to remember that whenever we wipe the eye, we are wiping from the inner canthus down and outward. So go from the inside of the eye, the part of the eye that's closest to the nose, and wipe out. So there is a difference that we see in the clinical manifestations between bacterial and viral conjunctivitis. So with a child who has bacterial conjunctivitis, they have a very purulent drainage. We see crusting of the eye, especially when they awaken, and their eyelids have an inflamed conjunctiva and their eyelids are swollen. So these are the kids that wake up in the morning whose eyes are glued shut because of the purulent drainage. Where a child with viral conjunctivitis has more of a watery drainage, they will have an inflamed conjunctiva and they will have a swollen eye, but they will not have the eye that's glued shut in the morning. And our viral conjunctivitis usually does occur with an upper respiratory tract infection. So with your allergic conjunctivitis, you'll see that the eye is itchy. The drainage can be watery to thick or stringy discharge. The conjunctiva is inflamed and the eyelid can also be inflamed. Usually with this type of conjunctivitis, it usually does affect both eyes. With a foreign body conjunctivitis, you'll see tearing because the eye is trying to get rid of what is in it. The kids will complain of pain. You'll see an inflamed conjunctiva, and what you'll see is usually just one eye is affected because usually only one of the eyes has the foreign body on it. It isn't often that you see both eyes affected. So treatment of conjunctivitis depends upon the age of the baby. You will learn in your OB class that all newborns receive neonatal birth prophylaxis with either erythromycin eye ointment or gentamicin eye ointment, and this is to prophylactically treat and prevent the spread of chlamydial infections to their eye. Children and infants who have bacterial conjunctivitis are treated with polymyxin and bacitracin, or with sodium sulfonamide or trimethoprim and polymyxin or polytrim. So these are the type of drops that we will be placing in the child's eyes. So nursing care really does surround around education. It would be unlikely that we would see these children in the hospital. If we do see them, they will have a respiratory component to their disease that we are seeing them for. So education really does include teaching the parents how to clean their eyes for the eye secretions. So a warm washcloth wiping from the inner to the outer canthus. It's very important to have them dispose of the tissues that are used for wiping, or only using the washcloth once and then cleaning it, putting it in laundry to clean. Not to reuse any cloths until they are cleaned. Medication administration is always important because remember, it is usually not administered properly. Hand hygiene so that the conjunctivitis isn't spread from person to person. No eye rubbing. And we especially want to educate them about the signs of serious conjunctivitis, which would include reduction or loss of vision, ocular pain, photophobia, decreased ocular motion, and corneal ulceration, and they will have to come to get further treatment if these develop. Epistasis is the medical term for nose bleeding. This is common in children. Nose bleeding in children usually result from direct trauma, which could be a blow to the nose, a foreign body, or the child picking their nose. Or it could be an inflammation that's associated with allergic rhinitis and an upper respiratory infection. Usually nose bleeding stops spontaneously or with minimal pressure in less than 10 minutes and generally requires no medical evaluation or therapy. However, recurrent or severe bleeding may be indicating an underlying disease such as hemophilia or other bleeding disorders. So it's important to control the bleeding, and we do so by asking the child to sit up and to lean forward and to apply pressure to the soft lower portion of the nose with both the thumb and the forefinger, and you want to instruct the child to breathe through their mouth. After the bleeding stops, it's important to moisturize the area. We can do this using petroleum or a water-soluble jelly, and this will decrease the likelihood of especially the younger children picking their nose because it will be moist. We can provide cool, moist humidification, and our nursing care really does evolve around controlling bleeding and education, especially educating children not to pick their nose. Next, we're going to talk about sensory disturbances, and this includes both hearing and visual impairment. So hearing impairment can range from slight to profound. So you can have slight to moderately severe hearing loss, which will be residual hearing loss sufficient to process the linguistic information through the use of a hearing aid. So with slight to moderately severe hearing loss, children are able to hear by using a hearing aid. However, when children have severe to profound hearing loss, there isn't an ability to successfully process the information through hearing with or without a hearing aid. Visual impairment is a general term that refers to visual loss and that cannot be corrected with regular prescriptive lenses. So when we're talking about visual impairment, we are talking about children's vision that's not able to be corrected through wearing glasses or contacts. So there are different causes for hearing impairment, which can include an anatomic malformation. Some children aren't born with the structure and function of the structures of the ears and hearing. Low birth weight, being low birth weight does predispose you to hearing loss. Receiving medications that are ototoxic, so can impair hearing. Some of these medications includes antibiotics, especially if it has been received in the newborn period. Children who have had chronic ear infections, perinatal asphyxia, perinatal infection, and cerebral palsy. So there are different types of hearing loss. So conductive hearing loss, it involves the middle ear. Sensory neural hearing loss involves nerve deafness. And then you can have mixed conductive and sensory neural loss that may follow recurrent otitis media with complications. You can also have sensory, auditory, and perceptions. So these losses are not conductive or sensory neural. There's usually some sort of organic or functional cause for this hearing loss. Symptoms, severity of hearing loss or impairment can be measured in decibels, and you also look at the hearing threshold, so what decibels they can hear or not hear at, and also look at the effect the hearing loss has on the child's ability to speak. So therapeutic management depends upon the type of loss. So you can have medical or surgical interventions. So children who have the conductive hearing loss can be treated with hearing aids, and children who have sensory neural hearing loss can be treated with cochlear implants. So clinical presentation can be variable depending upon the age. So in infancy, what we can see is an infant that has lack of a startle reflex. They won't startle to sound because they don't hear the sound. We may see absence of babbling by the age of 7 months. You'll see a child who doesn't seem to notice the sound and doesn't turn to sound. They have an indifference to sound. And also once children aren't speaking, they're not using any type of speech or sounds, we start looking at their hearing to make sure that they can hear. Profound hearing loss, hearing impairment is likely to be diagnosed in infancy, especially because we do hearing screens. So we do newborn hearing screens right away after birth. Each child who's born does have a hearing screen. And children that defer or fail the hearing screen have to go see an audiologist and have further, more sophisticated testing of their hearing done, because it's really important to identify hearing loss and to correct it as soon as possible. The other time we may see presentation of hearing loss is when the child enters the school, so that we might see difficulties with their schoolwork, and also when we see any types of concern with speech development. That is also a presentation of potential hearing deficiencies. So with hearing loss, we want to promote communications. So children are taught how to read lips. They learn how to cue speech. They learn sign language. They go to speech language therapy. We encourage socialization and any additional aids that we can help them to communicate and to interact with the world. So that can include telephones that don't ring but light up, show a light so that they can know that the phone is ringing. The same thing with the doorbell. There will be a light also with the sound so that they can recognize that somebody may be at the door. So nursing education does include reassessment of understanding of any instructions that were given. supplement with visual and tactile media. Usually when you have one sensory loss, your other senses are more acute. So people do rely on their other senses more. Different types of communication devices, especially if the child is nonvocal. That could be through a picture board, common words for different needs such as food, water, and toilet. They may also have a more computerized device to help them speak. We want to ensure that children get treatment and management of recurrent otitis media to decrease the incidence of hearing loss to occur, and also education on the care of hearing aids, especially keeping them powered so that the children don't lose their ability to hear. So cochlear implants can be used to treat children who have sensory neural hearing loss. This provides sensation of hearing for individuals who have had severe or profound hearing loss. And what happens with these implants is that there's bypassing of the hair cells to directly stimulate the surviving auditory nerve fibers so that the children have a signal that is sent to the brain which will produce the sound and the sensation so that they can hear. And this is a picture of a child with a cochlear implant. So now we're going to move on to visual impairment. And remember, when we're talking about visual impairment, we're talking about vision that cannot be aided by the use of glasses or corrected by the use of glasses. So children can be partially sighted, so they can have an acuity of 20/70 or to 20/200. And education is usually, for these children, they usually are educated in the public school system. And then you have your child who is legally blind, so they have a visual acuity of 2200 or less. And so this is the legal blindness is a legal term as well as a medical term. And these children also oftentimes receive their education in a specialized school for the blind and not in the public school system. So causes of visual impairment vary. Visual impairment can be caused by a perinatal or postnatal infection such as gonorrhea, chlamydia, rubella, syphilis, and toxoplasmosis. It is because of we worry about gonorrhea and chlamydial infections in newborns that we do the eye prophylaxis. Children who are born prematurely can develop retinopathy of prematurity or ROP. And what happens because they're born so early and because of the medication and the oxygen that they receive, their retina does not grow well, and it can actually detach from their eye. It can also, visual impairment can be due to perinatal or postnatal trauma. And then there's plenty of children also who have visual impairment that we have no idea why it has happened. So the visual impairments or the refractive errors that we see that are corrected by glasses are myopia and hyperopia. And so refraction is the bending of light rays through the lens of the eye, and it's through this that you are able to see. So myopia is nearsightedness, hyperopia is farsightedness, and some children also have strabismus, and this may or may not be refractive. And then there's other type of visual impairments that include astigmatism, amblyopia, which is lazy eye, strabismus, which can have an inward or outward deviation of the eye, cataracts, and glaucoma. And these can all cause a type of visual impairment, but a lot of these are able to be corrected, where our other the previous visual impairments that we talked about are not able to be corrected. So nursing care evolves around encouraging play and socialization, development of independence. From an educational standpoint, these children may learn to read Braille. Sorry about that. They will probably listen to audio books and have more audio learning materials. We want to ensure a safe environment. So this is a type of environment where the families don't change the locations of their furniture often, because the child really learns how to navigate the area by routine and knowing where they are in the house. So moving a chair can cause them to end up harming themselves. We want to reassure the children that they can have quality of life, orient them to their surroundings, encourage independence, and consistency of team members, especially in the hospital, is important, because we will be used to the child's routine and the child will get used to us. So children who have both visual and hearing deficiencies, children who are both blind and deaf, this does profoundly affect their development. Remember, I talked about before, when one sense is lost or decreased, then the child really does have a heightened ability to use a different sense. And so generally with blind and deaf children, their motor milestones are usually not achieved, and other developmental achievements are oftentimes delayed. These children can be taught how to finger spell, so they can spell words within a hand. You can spell the words within their hand so that they can feel the different levels. And we need to help the children and family develop future goals for the child that are realistic and achievable.